Good morning, Madam Chair.
Good morning.
And did you say your name? State Senator Al Worship from Aberdeen, representing District 3. Today I bring you House Bill 1080. The Help Not Harm Bill prohibits doctors from blocking healthy puberty and prescribing cross-sex hormones or performing surgeries to modify a child's body to appear more like the opposite sex. The law would only apply to minors under the age of 18. This morning, I'm going to talk about decision making. When I was in high school, I had a job building grain bins. After a long, hard day at work, I came home and collapsed on the living room floor from exhaustion. To get comfortable, I removed my glasses. I put them on the floor beside me. Later, Mom walked by, and she stepped on my glasses. My rapid-fire decision was to yell at Mom, "Mom, you're an old cow." Oh. Bad decision. In 1 second, I went from the victim of the accident to the problem. It did not end well. Many times, rapid decisions in a young brain does not end well. The following concerns good decision making versus bad decision making. In 2011, the legislature approved House Bill 1217 that said a woman that was considering having an abortion would have a 3-day waiting period to decide if that was the best course of action for her. Hundreds of children are alive today in South Dakota because the legislature said the women should have more time to make the permanent decision to have an abortion. That's what we're talking about today, taking more time to make a permanent decision. I apologize, I left the phone. Here's the story of one of those children. His name is Tomias. Tomias is 6 years old. Tomias is happy, well-adjusted, and very loved. He loves his dog Brinkley, and he loves all things sports. But he had a very rocky start. You'll see if there was not the waiting period in South Dakota before the abortion, he would not have been here today. His mom was being pressured to abort him, taking the time needed to think and seek the help to finish her pregnancy with love instead of fear. Tomias's adopted family adores him, and his birth mother is halfway married now and has 2 twins. I would say that's a double blessing. Time was Tomias's best friend. Imagine being a 10-year-old, a 13-year-old, or a 17-year-old in South Dakota, and the adults in your life guide you to having your breast removed or being chemically castrated. Then you turn 22 and you meet the love of your life, a member of the opposite sex. The legislature protects the young by allowing them to not drink, smoke, buy cigarettes, buy over-the-counter cough syrup, or gamble. And in some states, you can't get a tattoo if you're under 18. I wish the legislature could have protected me the day I made the bad decision with Mom. Please vote to protect the young from making a bad decision. Thank you, Madam Chair and Committee.
Thank you. Any further proponent testimony? Welcome.
Thank you, Chair. I'm Bethany Soye, and I'm a representative from District 9, and I am the House Prime Sponsor for HB 1080, South Dakota's Help Not Harm Act. Medical providers in our state have become increasingly bold about the harmful chemical treatments and experimental procedures being conducted on children in our state. In the guise of medical treatment, children are being mutilated, sterilized, and turned into permanent medical patients. Children as young as 8 years old are taking puberty blockers, 13-year-olds are being given cross-sex hormones, and a leading South Dakota physician recommends that girls struggling with their identities receive double mastectomies while still in high school. We need to stand up for the vulnerable children in our state. We care deeply about children who are struggling with their identities and want to provide them with true, meaningful help not permanent physical damage. This bill will prohibit 3 things: the use of puberty blockers to stop healthy development, the prescription of cross-sex hormones, which often leave children sterilized, and the irreversible surgeries that leave a child's body permanently damaged. This bill is personal for me. As a child, I wanted to be a boy. I wore boy clothes and I made a boy name for myself, and in 3rd grade I wrote that name on all my class assignments. But my parents and my teachers didn't take me in for medical treatment. They just loved and supported me and allowed me to be a kid. I went through natural puberty and came to love being a girl. I now have 2 children, and I'm so glad to be a woman. The science is with us. Countries like Sweden and Finland, where these procedures first took off, have stopped prescribing puberty blockers and cross-sex hormones for patients under 18 because they have seen the permanent damage that these drugs cause to children. The studies show that when left to progress through natural puberty, from 80 to 90% of children struggling with their identities will come to accept and thrive as their biological sex. That's why this bill is needed now. The opposition will tell you that this decision should be left to parental choice. But even here in South Dakota, parents are often denied access to their children's medical records. I'm not talking about California, I'm talking about South Dakota. This is happening here. Parents are also often given an ultimatum with the non-scientific statement that transition is the only remedy for suicidal ideation. We need to stand in the gap for vulnerable children and their parents and guide them towards true health and healing. Like the previous speaker said, rapid decisions often do not end well. And all that we are asking for here is a little more time to make a permanent life decision. So today I'm asking for your support in taking action and passing HB 1080, South Dakota's Help Not Harm Act. I do have a handout of organizations that have endorsed our bill, if one of the pages could hand that out. And of note is Governor Nome also supports our bill. Next we'll have Chloe Cole.
Thank you, Representative. Any further proponent testimony? Welcome.
Hello. My name is Chloe Cole, and I am a detransitioned 18-year-old woman from California who went through the process of medical transition between the ages of 12 to 16. The 3 main interventions I was given were puberty blockers and testosterone, starting at 13 and a double mastectomy at 15. I was treated negligently by my healthcare provider, but the biggest failure they made was encouraging and allowing me to medically transition as a child in the first place. My therapist and gender specialists failed to address several underlying circumstances and comorbidities that led to the onset of my gender dysphoria. I began puberty when I was no older than 8 or 9, and so from a very young age, I had a lot of discomfort around my developing body. I was afraid to go from a girl into a woman and experience things like periods, childbirth, and menopause, because I often would only hear about how scary and painful being a woman from other girls was from other girls and older women. I never really had any strong female role models, and I often never really fit in with other girls, but I did have a tomboyish streak due to the influence of my older brothers. I had previously been diagnosed with ADHD, but I actually am on the spectrum, though I was not diagnosed until I was 17. The gender specialist who referred me to surgery also was the same one who later recommended me to get a screening for autism. Because I am autistic, I have some more masculine behaviors, and I am more object-oriented than most girls. I have some social, cognitive, and sensory processing differences that made school and going through puberty a little bit more difficult. All things considered, though, these struggles were all normal, but were misrepresented as problems having to do with my gender. I have suffered a multitude of complications from the blockers, cross-sex hormones, and surgery. My quality of life is still being impacted to this day. I had my puberty blocked when I was already about 3 or 4 years in, and so I started experiencing some menopause-like symptoms, including severe hot flashes and itching all over my body. This went away after I stopped taking them, but I still have some joint pains and shooting pains up my spine. During a consultation for testosterone, I was told by my endocrinologist that I would experience vaginal atrophy. I was not informed that this atrophy actually affects the rest of the organs in the pelvic region. It caused me to experience episodes of severe uterine cramps that were rare but unpredictable and worse than any menstrual cramps I've ever experienced. I was prescribed topical estrogen, but my urinary tract was still affected, and I am still susceptible to dehydration and infection. The status of my fertility is unknown, but I do not have the choice of breastfeeding my future children because my breasts are gone. I was told this by my surgeon, but I did not understand the importance of breastfeeding or even being a parent because I was still a child. I am now grieving as an adult, and on top of that, the areola skin grafts they used in my surgery began to fail 2 years afterward. I have to wear bandages over my chest every day. The doctors who helped me to transition have not given me the appropriate care for any of these complications either. You may be wondering what role my parents played in this, and whether I was forced by them to endure this. In fact, they were quite shocked when I first told them about my feelings of discomfort around my birth sex and my desire to be seen as their son. They wanted me to be comfortable, but they were not okay with me going beyond cutting my hair shorter and dressing like a boy. They wanted me to explore without intervention and wait until I was legally an adult to let me decide whether I wanted to go the medical route. But when they expressed this to my doctors, their concerns were immediately dismissed, and they were lied to. They were told that all children are confident in their gender identity from a very young age, that the regret rate of transitioning is less than 1 to 2%, and were I not affirmed in my identity and decision to transition, it was likely that I would commit suicide. They were not given any other option. My parents were forced to make this decision under duress. But even if they were on board with me transitioning medically from the start, no parent, or any adult really, has a right to determine whether a child gets to be chemically sterilized or mutilated. Under most circumstances, this would be called abuse. But somehow, we've managed to market procedures that take away function from the body as necessary, life-saving health care for children and adults alike. HB 1080 will protect other children and families in this state from medical experimentation and defend the greatest right that children have, the right to grow up into healthy adults who are able to live fulfilling lives. Thank you for choosing to stand up for the health and safety of children.
Thank you for your testimony. Any further proponent testimony? Welcome.
Thank you, Madam Chair, members of the committee. My name is Burleigh, and I used to be transgender, and I'd like to share with you today my experience and lessons learned. As a child, I had the recurring thought that God made a mistake, I'm a girl. I prayed before going to bed every night, and I asked God, please make me a girl before I wake up. If I could have, at that point, I would have quickly chosen any path that would have transformed me into a girl. When I was in my 20s, I sought help for the disconnect between my mind telling me I was a woman, my body telling me I was a man. In seeking help and doing my own research, the message I received was that I had to change my body to match my mind. After seeking any other path forward, I decided to take the therapist's encouragement and the advice I read in the journal articles and in the books to change my body. In my mid-20s, I started on testosterone blocker and estrogen. My emotions were up and down and my body was changing, but I supposedly was on this new road to happiness, and that made me happy. In my first surgery, I had a penile inversion, an Adam's apple shave, and a brow shave. After the surgery, the surgeon and nurses had difficulty stopping the bleeding from my new man-made vagina. My artificial vagina was packed with gauze, and a sandbag was placed on my lower abdomen, but the bleeding did not stop. Later, my mom told me that going into my hospital room was awful. There was a pungent odor in the room of stale blood, my blood. I received a blood transfusion and units of plasma, and eventually the bleeding stopped. My 2-week stay in the hospital turned into a 3-week stay. The change in my penis to an artificial vagina required 2 surgeries, so about 4 months later, I was back for part 2. I was desperate for the happiness I believe was ensured me. After this, I had more body and voice feminization surgeries. But no matter how many I had, every time I looked in the mirror, I saw a man staring back at me. I tried hard to resolve the conflict between my mind and my body, but after 7 years of trying, I had more problems at that point than I had when I started on the road to transition. Suicidal thoughts were coming into my mind. I was in a pit of despair. The encouragement I received from the therapist, the books, the journal articles, they were wrong. In the pit of despair, I called out to Jesus of Nazareth. I gave my life and all of my problems to him, and at that point, he set me on a road to recovery that no therapist or medical professional was able to do. Later in life, after detransitioning, I heard it said that everyone has the need for acceptance, security, and significance. Though I hadn't heard this before I agreed with this statement, I started to think about how I had tried to satisfy these needs in my younger years. I had some problems as a child. I was very skinny. I had a speech impediment. I was picked on. Had learning difficulties. I wasn't athletic. I didn't seem to fit in with the boys. I did, however, seem to fit in well with the girls. I enjoyed playing with them more than I enjoyed playing with the boys. As a boy, I didn't feel accepted, secure, and I most certainly didn't feel significant. But if I were a girl, I believe I would have felt accepted and more secure. And with my childlike thinking, I may have been more significant. In hindsight, I see that I had several underlying problems that reinforced the false thought that I was a girl, including being sexually abused in the 6th grade. The therapist never did uncover, never did delve into these underlying issues. And my research on transgenderism failed to turn up anything on these 3 needs for acceptance, security, and significance. Transitioning did not help my mental health issues. I still had to deal with those after I detransitioned. As you can see, I'm fully detransitioned. I'm back presenting as a male, my birth gender. I'm happily married. I have 2 beautiful stepdaughters, and I have peace of mind and body. Lastly, I was past the age of responsibility when I made a horrible decision. In hindsight, I am male, and I was born into the right body. The therapists and medical professionals failed to help me with my underlying mental health problems. They identified me as transgender, and they were wrong. How often are they wrong? I ask you to please support House Bill 1080. I truly wish I would have received mental health care instead of the gender-affirming care I did receive. Thank you for hearing my testimony.
Thank you. And how much time do we have left?
I'd like to go online.
8 minutes of time left. We can go online.
Dr. Hanson.
Dr. Hanson, would you like to go ahead?
Yes, I need my camera turned on.
I think that was a question.
Madam Chair, members of the committee, it is my high honor to be able to speak to you today on the perils of early affirmative care. And Chloe and Billy, I am so sorry for what you went through, but I am so encouraged by your bravery to present today. I'd like to start, and again, I'm Dr. Jeff Hansen. I'm a pediatric and adolescent clinical psychologist at a staff physician in Madigan Army Medical Center. I'm also recently been appointed the clinical director at Hold Fast Recovery, and also have a small private practice. I've been practicing for about 40 years. I'd like to start, if I could, by way of an apology. I'd like to apologize for my profession of psychology, because as PhDs we have an obligation in our research that either supports or fails to support our therapeutic methods, and I do not believe that this is the case. So in just a decade, when the DSM-5 was first published in May 13, 2013, it reported the expected incidence of gender dysphoria was at 0.005 to 0.014% for natal males and 0.002 to 0.003 for natal females. In less than 10 years, the incidence of gender dysphoria has increased a staggering 1,000%. How could it be that now 2% of high school students now identify as transgender? And this is a phenomenon not just in the United States, but across Western culture. So gender affirmative care is in 4 phases. We have social transition, which starts as early as 3 to 4. No child at 3 to 4 can really understand and appreciate permanent decisions. Puberty blockers in boys, 10 to 14, girls 8 to 13, cross-sex hormones as early as 14, surgical modification 14, 15 to 17, in some cases now as early as 14. The side effects of blockade have already been reported in this hearing, but I'm going to go over them a little bit more in detail. The side effects of blockaded normal puberty blockade include stunting of penile and testicular growth, sexual dysfunction, impairment of erection, orgasm, ejaculation, prevention of sperm production, disruption of normal brain development, and disruption of normal bone density. In females, you see a menopause-like state, blockaded normal breast development, decreased blood flow to the vagina and vulva, sexual dysfunction prevention in menses, disruption of normal brain development as well, and also disruption of bone development. Neuropsychological effects of puberty blockers include emotional ability, mood changes, headaches, nervousness, anxiety, agitation, confusion, delusions, insomnia, depression. Medical staff are encouraged to monitor the development of psychiatric symptoms, use with caution in patients with a history of psychiatric illness, and also watch for suicidality. Bone density is greatly decreased. The side effects of cross-sex hormones for males on estrogen, there's an increased risk of myocardial infarction, death due to cardiovascular disease, thromboembolism is a 5 times increased risk, gallstones, increased triglycerides, breast cancer risk increased by a staggering 46 times, gynecomastia, sexual dysfunction and infertility, females on testosterone, increased risk of myocardial infarction as well, erythrocytosis, which means too many red blood cells, severe liver dysfunction, hypertension, breast, uterine, ovarian cancer risk, hirsutism, which is hairiness, deepening of the voice, sexual dysfunction, and fertility. By the way, when you are on puberty blockers and cross-sex hormones, there's a guarantee that you'll be sterile, and also a near guarantee that you'll never have an orgasm. Little children do not understand what that is and how important that might be to healthy life functioning. The Swedish study, one of a classic study, is a 30-year longitudinal study. Started in 1973 and culminated in 2003 and published a little bit later. At 10 years out, so most of the studies that we see that support transgenderism are short-term studies, and there are lots of loads of procedural problems in the studies. But at 10 years out, you have a 19 times increased risk of, not risk, but a completed suicide. So that is a staggering and very negative outcome. What are some of the potential causes for the rise in transgender identification? I'm just going to list them. I'm not going to go into any detail because of time. Autogynephilia, which is basically the desire to see yourself and actually being stimulated by the thought of being the other sex, seen males. Homophobia, influence of role models, rapid onset gender dysphoria, at least a Lipton study, which showed that there's been a dramatic, this is a parent interview study out of Brown University, that teens have this rapid onset of wanting to change their sex, primarily in females. We also have childhood trauma, and we know that trauma produces codes in the body. Trauma causes a sense of disassociation, a feeling of malaise in the body, and many young people will look for a quick answer to their transgender, to their trauma, to the feelings that they have, and they'll assume that trauma is the sexual transgender is the issue, and they just change their sex, they'll solve what they feel in their bodies. Sadly, that's not the case, and I see lots of this in Madigan, and also in my private practice. There's a mental health crisis in today's youth, and again, children are searching for the answer, and they're assuming that this is going to cause and solve their mental health issues, and it doesn't. The impact of pornography has been a huge influence, and we're seeing many children change sexual orientation, change their sexual appetites as a result of pornographic exposure. And finally, autism. Chloe spoke to that already eloquently. But autistic folks tend to have a tendency to think concretely, and can get locked onto this and change without really understanding the nuances therein. So I propose, and it has been proposed, a wait-and-see approach, watchful waiting, which enables a child to guide the course that they will take. They may or may not eventually decide to go forward through transitioning. In the therapeutic approach or the developmental approach, it allows for the child in question to explore the parameters of their gender, while being open to the possibility that he or she may eventually grow out of it on their own in the sex that they were born as. The therapist would endeavor to understand possible relevant factors, development to provide adverse child experiences, to include adverse child experiences, trauma, and other psychopathology, or whatever else might be happening or transpiring that might be moving the child to feel this way. And we know, as I think alluded to earlier, that studies indicate, and there are many studies that support this, that approximately 80% of child onset dysphoria resolves by age 20. A majority of the children who have gender dysphoria may end up being same-sex attracted. And some practitioners claim that they can tell clinically in early puberty who will persist in their gender dysphoria, but there are really no validated protocols. So when I was 10, I wanted to be a pirate, but my parents wouldn't let me pluck my eye out. Why are we letting our children do these things? Why are parents supporting this? And I think we need to read and take a close look at what the research is telling us. Thank you so much for your time.
Thank you. We are out of time, but we have somebody online. I'm gonna give a chance for Me Too's, for anyone who wants to give one.
Yep, I saw we're out of time. Norman Woods, FHA Action, Me Too.
Thank you.
Matthew Monfort, Christian Baptist Preacher, Jesus is King Mission, Me Too.
Florence Thompson, lobbyist for South Dakota Parents Involved in Education, Me Too.
Thank you. And Mr. Donovan online, would you like to, or excuse me, yeah, Mr. Donovan online, are you a proponent?
Yes, I'm a proponent. I'm speaking for myself, but I'm part of LGBT United, and I'll add a Me Too. Thank you.
Thank you. Any other Me Too's in the room? Seeing none, we will move to opponent testimony.
Is that your camera? What's this?
Good morning, Madam Chair and members of the committee. My name is Elizabeth Brockmeyer, and I'm a resident of Sioux Falls, South Dakota. Come this May, I will have called South Dakota home for 30 years. I grew up in Sioux Falls, and I earned my Bachelor of Science in Sociology from South Dakota State University. I volunteer for various organizations in my community. My 2 children, ages 13 and 7, were born here. I would say that we are a typical South Dakota family. Homegrown is what I like to call us. When my child was 11 years old, he had the courage to tell his dad and me that he was transgender. He was met with love, compassion, and acceptance. Looking back now, there were clues that he was always struggling with his gender identity from a very young age. He often presented more tomboyish qualities. At the time, we thought nothing of it. However, our requests to present more feminine for a holiday gathering or special occasion were met with anxiety attacks. At the onset of puberty, our son also became more distraught, withdrawn, depressed. Typical effects of puberty that most would view as inconveniences became life-altering changes for him. He would be inconsolable, sometimes even expressing that he wished he had never been born or that he was dead. After our son came out, his dad and I did what any parent would do when their child presents with a medical issue. We made an appointment with his doctor. The decision for our child to receive gender-affirming care was not made brazenly. It was deliberate, careful, comprising of months of visits with several doctors, his therapist, and frank discussions with him as well. All of us, as a team, came to the informed decision to provide gender-affirming care for him. This decision is one that I do not regret, because statistics show that if my son is not provided gender-affirming care, there would be a strong chance that I will be burying him. The last couple of years have not always been easy. I've had to hold my son, comfort him as he has dealt with bullying and dysphoria. I've tried to help him understand why other people, mainly adults, would dehumanize him, ridicule him, make him feel less, solely on the fact that he is choosing to live life as his authentic self. He listened last week to the testimony in the House Committee, where he was basically likened to a medical experiment from those that supported this bill. He's experienced pain that I, as a parent, can't carry for him, but I can help him on this journey. This journey has had several bright spots. I've been fortunate enough to watch him blossom into a wonderful young man. He's a straight-A student, plays in the school band, was recently cast in his first school musical, and was named the January Student of the Month at his middle school. He has your typical teenage attitude at times, but at the end of the day, he still loves his mama. At this juncture, I'm not asking you to completely understand gender-affirming care. I'm not even asking you to put yourself in my shoes as the parent of a transgender child to see how you would react to a bill like this being brought forth. I am, however, asking that you put yourself in the shoes of a parent that is being told that the care that you and your child's medical team have decided upon is not allowed and is not okay. That lawmakers have better knowledge than a team of medical professionals and better intentions than a loving and concerned parent. Ultimately, the message this bill sends should frighten all parents in South Dakota. This bill strips the rights of parents to make an informed decision with their child's medical team for the best course of care. The government has no place interfering with medical care for a child. Medical care that is life-saving and is supported by both parents and medical professionals. Our children are watching, and I strongly urge you to vote no on this bill. Thank you.
Thank you. Any further opponent testimony on HB 1080?
Good morning, Madam Chair and members of the committee. Thank you for giving me the opportunity to address you. My name is Dan Heineman. I'm a family physician, a specialist in family medicine, and a registered lobbyist for the South Dakota Academy of Family Physicians. The Academy represents over 500 physicians, residents, and students in South Dakota. The Academy and its members are committed to providing comprehensive, high-quality health care to the citizens of South Dakota. And today we speak in opposition to House Bill 1080. The South Dakota Academy of Family Physicians is a component chapter of the American Academy of Family Physicians, the AAFP. The AAFP recognizes that diversity in gender identity and expression is a normal part of the human existence and does not represent pathology. The AAFP supports access to gender-affirming care for gender-diverse patients, including children and adolescents. Gender-affirming care is part of comprehensive primary care. Family physicians are uniquely suited to provide gender-affirming care because of their whole person focus. Family physicians are deeply concerned by the growing trend of recent legislative efforts to criminalize care or characterize the care that we provide as mutilation, castration, and other horrible terms that are not necessarily part of our medical vernacular. We especially are concerned about these kinds of laws that are directed at patient-specific populations, and HB 1080 does just that. Physicians must be able to practice medicine that is informed by their years of medical education, training, and available evidence freely without the threat of punishment. Clinical guidelines instruct physicians to use mental health resources and support the child and their family. Surgical intervention is not part of the initial clinical guidelines for pre-pubertal children. Therapies are started only after significant mental health evaluations, extensive medical evaluations to assure that the recommendations for care as indicated is appropriate. Parents are also part of a significant informed consent process and have the final say in the decision to treat. Puberty blockers are reversible and the effects stop when medications are stopped. Some additional facts, members of the committee. After Arkansas became the first state to ban gender-affirming care, healthcare in minors, the state experienced an uptick in suicide attempts in young people. A longitudinal study of 50 transgender adolescents found that suicidality was decreased by a statistically significant degree after receiving gender-affirming hormone treatments. As previously stated, puberty blockers and hormone therapy only become options after robust mental and physical evaluation and long discussions between parents and adolescents and their physicians. A lot has been made about Sweden banning gender-affirming care. That is not true. If you read the guidelines from the National Board of Health in Sweden, they talk about providing this care in specific institutions and under specific guidelines. I don't know what it was like before they implemented these guidelines, but I can tell you that gender-affirming care is still done in Sweden, despite the claims of some of the proponents. And guidelines, it's not unusual for guidelines to involve all stakeholders in the development of guidelines. And criticism has been made that folks who support gender-affirming care have been part of those guideline developments. For these reasons, South Dakota's family physicians ask you to defeat House Bill 1080. The defeat of this bill will allow physicians to provide the evidence-driven evaluation of adolescents and their parents who seek information and options and the true risks of gender-affirming care. Thank you for your time, and I will stand by for questions.
Thank you, Doctor. Any further opponent testimony to HB 1080? Welcome.
Thank you, Madam Chair and members of the committee for allowing me, excuse me, to speak this morning against HB 1080. I am the Reverend Dr. Lauren R. Stanley. I am assistant to the Bishop of the Episcopal Diocese of South Dakota, which has 79 congregations across the state. This diocese and the Episcopal Church stand firmly against HB 1080 because it is immoral and violates every tenet of the gospel, which declares that all children are beloved of God. This bill puts a target on every single child who believes they are transgender. This raises the question of whether HB 1080 actually is in violation of the Federal Hate Crimes Act, the Shepard-Burt Act, because HB 1080 will place a target on every trans child in South Dakota and could actually encourage not only bullying, but physical harm. This bill doesn't protect children. Rather, it labels these children as lesser human beings, unworthy of medical and psychological care. If it is passed, HB 1080 would deny children their innate rights as beloved children of God and would delegate them to second-class citizens. They would be unable to receive the medical care they need. This most likely, according to all of the studies, would drive these children to suicidal ideation and suicide attempts. We already have an epidemic of youth suicide in this state. We already have that. I know for years, I was the one who buried the children on the Rosebud who had lost their lives to suicide. I know how dangerous this bill will be to children who are simply trying to figure out who they are. Because this bill, if it passes, it's going to add to the epidemic of suicide. I am begging you, do not pass this bill. Do not tell these children that they are not beloved of God. Do not tell these children who are sacred that they are not sacred because they are not quite certain who they are. Do not pass a bill that will encourage teasing, bullying, and quite possibly physical assault. Do not encourage these children who are simply trying to figure out who they are to entertain, much less act upon, suicide ideation. We are the adults. We have a sacred obligation to care for these children. This is what God has instructed us to do. And in the name of God, who has asked each and every one of us to care for all of God's beloved children, regardless of their sexual identity or gender, regardless of their color, their race, their ethnicity, regardless of who they are, God has entrusted their care to us. And I beg you, do not pass this bill because we won't be able to care for our children. Thank you for allowing me to testify, and I will stand by for any questions.
Thank you. Any further opponent testimony? Welcome.
Good morning, Madam Chair, members of the committee.
And there's about a little over 11 minutes left.
Thank you. My name is Samantha Chapman. I'm the registered lobbyist for ACLU of South Dakota. We oppose this bill on several different grounds. Constitutionally, this discriminates against individuals based on sex, discriminates against individuals based on transgender status, and it violates parents' due process clause rights. It's a huge government overreach into the patient-provider relationship, which we know is very important. We've heard from several medical providers already on this. I do want to talk about the civil penalty section of this bill. State medical malpractice is a 2-year statute of limitations, but this bill lines out that a patient can sue, or somebody can sue, up to the age of 25 or 3 years after injury has occurred. So if a physician provides care, let's say puberty blockers, to a 12-year-old patient, that physician is now liable until that patient turns 25. That's 13 years of a statute of limitations with which somebody could file suit against that doctor. Specific carve-outs in statute for individual types of medical care create treacherous landscapes for our healthcare providers, hospital systems, and insurance providers. 1080 violates the fundamental rights of parents to take the custody and care of their minor children. The liberty interests of parents in the care, custody, and control of their children is perhaps the oldest of the fundamental liberty interests recognized by the Supreme Court. HB 1080 bars treatment in cases where the treatment is recommended by physicians and supported by parents and their minor children. Such an intrusion into the medical decision-making of parents infringes on their due process rights. We've seen the proponents of this bill. The sponsors are here from South Dakota, but everyone else that spoke to this isn't from here. They're from out of state, they travel around, and with all due respect, proponents of this bill are pushing a nationwide effort to shepherd people from state to state. But people who live here in South Dakota, doctors, patients, and youth, don't want this bill. Transgender young people, their parents, their doctors are in the best position to decide the appropriate medical treatment for each minor patient. This is an unprecedented intrusion into the complex and private dynamics and decisions of South Dakota families. For these reasons, we urge a no vote.
Thank you. Any further opponent testimony? And we have 9 minutes, 20 seconds.
Madam Chair, members of the committee, my name is Justin Bell. I'm an attorney from here, and I'm a registered lobbyist for the South Dakota State Medical Association. I do have a handout if there's a page available for the committee. Actually, 2. I'm here today to voice the opposition of the South Dakota State Medical Association, HB 1080, and its members, which will prohibit certain care for minor transgender patients. We often hear in these chambers about parental rights, about limited government. HB 1080 stands directly in contrast to those concepts. It's legislation that would intrude on the patient-physician relationship and prevent physicians from providing evidence-based care and medical treatment to minor patients despite the consent of the patients and their parents. And that's important when we talk about this. This isn't just a kid going up to a physician without consultation and requirement for parental consent for these matters. The South Dakota State Medical Association has long opposed legislative and bureaucratic interference in medicine by government or other third parties that cause the physician to compromise his or her best medical judgment as to what information and treatment is in the best interest of their patients. Under the proposed bill, a physician would lose his or her medical license and be subject for significant liability for longer than the current statute of limitations, as was previously discussed, simply for following the Hippocratic Oath, which is to care for patients and to provide best practice medicine in his or her best medical judgment. Access to care for transgender people is an important means of improving health outcomes. Receiving care is linked to reductions in the rate of suicide attempts, decreased rates of depression and anxiety, and decreased substance abuse or use in transgender people. Those positive effects extend to those under the age of 18, and I'll just briefly talk about the two things that I handed out to you. I did talk to some folks in the health side after they had their hearing, and one thing they said, you can't just say that. You have to provide some kind of documentation to prove the fact that that's true, and so that's a fair point. I want to look at the science studies, and I pulled out two that were just released in 2002. I know you aren't going to have time to read the entirety of two medical studies, but one was published in the Journal of the American Medical Association regarding a study that showed, and I think this is important, specifically showed there that having medical care, including puberty blockers and gender-affirming hormones, was associated with a 60% lower odds of moderate or severe depression and 73% lower odds of suicidality over a 12-month follow-up for youth. Okay, and this is specifically directing towards youth that are having this type of care that we banned specifically in sections 1 and 2 of the hormone treatment puberty blocker bill. Similar results in the public or PLOS1 journal. That included 27,715 transgender adults looking back at the medical care they received as minors. Similar results showing the same results. So I don't want anyone to say that I'm just coming up here and saying and making accusations about the medical and the journals for peer-reviewed medical science for that. South Dakota is suffering from a high suicide rate among our teens and young adults already, and this legislature right now is considering funding significant amounts of money to support those efforts, and that's commendable. We should do that. But passage of HB 1080 will have adverse effects and worsen mental health for transgender youth. And I think it's important to know, and I'm not going to go a lot into it because it was talked, but 8th Circuit has already looked at a bill that's almost identical to this, passed in Arkansas, was mentioned, and had already affirmed preliminary injunction on that bill out of Arkansas, finding that it was most likely unconstitutional. That's the standard in a preliminary injunction. I'm not going to get into a whole lot, but the commission should at least be aware of the fact that this is currently in litigation. Every sign points towards the fact, at least as of now, the district court has found that it was enjoined and they haven't made a decision. 8th Circuit's affirmed towards that. But in this exact circuit, the 8th Circuit is the circuit that South Dakota is in. The 8th Circuit has already said this is most likely unconstitutional. One may want to consider pausing and waiting and see what happens in that litigation prior to passing the same bill that likely is going to be ruled unconstitutional as well. With that, I would state that physicians have an obligation to act in the best interest of their patients. South Dakota State Medical Association opposes government interference with very difficult medical consultations and decisions that are made by patients, physicians, and minors already, and would urge a no vote on House Bill 1080. Thank you.
Thank you. Any further opponent testimony? We have just under 4 minutes.
Thank you, Madam Chairman. Lindsay Ryder-Rapp, I'm a registered lobbyist with the South Dakota Association, the South Dakota chapter of the American College of Obstetricians and Gynecologists. I just want to go on record as being an opponent. I know there are at least 3 online testifiers that we could go perhaps to Andy, Dylan Schneider, if we may. Thank you.
Thank you. Yes, we can go to Annie online. Are you there?
Yes, I am. Is there, how do I find my face? I'm not sure how to do that. I think that should work. Okay, hopefully that works. Am I on? Yes. Okay, so I'm Reverend Dr. Ann Schneider. I live in Sioux Falls. I'm licensed in South Dakota as a mental health counselor. I've been accompanying transgender persons for 31 years. A doctorate in clinical psychology, I completed a postdoc residency in Fargo, autism and neurodiversity, and I did an additional 2 years of specialty training in the International Federation of Transgender Care. To have the care, it's really important that you know as a committee that to have the care of gender diverse children and adolescents within our scope of practice, licensed mental health providers, which is where the treatment process begins, have to have training and expertise, both in child, adolescent, and family mental health, in gender identity development in children and adolescents, and also training and expertise in autism and neurodiversity, and I have all of those. The current International Standards of Care, version 8, was released in September of 2022. And the 5-year development process included a review of all the known research by the Evidence-Based Practice Center at Johns Hopkins University. We have 260 pages of protocols that include 68 pages of clinical research references, and I did not print it all out for you because it would have been a few trees. It is important to know that no country has passed a ban against care for transgender children and adolescents, and no care, as Dr. Heinemann said, is being denied minors in Sweden or anywhere in Europe. On December 12th of 2022, the Swedish National Board of Health announced their updated treatment recommendations. Those are based on 60 years of evidence-based practice. And they reported that the benefit of the treatment of minors far outweighs the risks of non-treatment. So in Sweden, just like in the US, medical necessity must be established on a case-by-case basis in order to prescribe any kind of medical treatment. And one of the big differences between Sweden and the US is that all transgender care and all health care is free. But following the standards of care in Sweden and in the United States, there is no medical treatment of prepubescent minors, none. So those children, all we do is focus on child and family well-being. That's the primary goal, and that includes counseling and social support. And I should note that South Dakota Medicaid will not cover this counseling. There is no outcome, transgender or not, is to be privileged by the healthcare providers involved in the child's care. That's really important because kids do change over time. But for gender diverse adolescents who've reached puberty, according to both our international standards of care, our individual professional standards of care, as well as insurance coverage requirements, which make sure we're dotting every I and crossing every T, we have to do a comprehensive assessment. And this is done collaboratively with the adolescent and their parents together. It takes months.
Ms. Dillenshiner?
Yeah.
We are out of time. I'll give you a quick 30 seconds to wrap it up, okay?
Okay, so what you need to know is what's covered. First of all, we do an autism evaluation. We also look for learning disorders. That has to be done. We have to look at social development, gender identity development, their capacity for decision making, which in teenagers can be a challenge. Then we need to establish medical necessity. We have to meet all these criteria of meeting Tanner Stage 2 in development. They have to meet the ICD-11 and the DSM-5 diagnostic criteria. That's a very high bar. Their incongruence has to be marked and sustained over the years. There's no rapid onset gender dysphoria. There's no such thing. They have to demonstrate emotional and cognitive maturity, again, a high bar, and all of the mental health conditions have to be addressed. My typical report is 12 to 15 pages, single-spaced, and then all that's done with parents, and then when they are met with their medical team, again, there's another round of assessment. I do want to point out that if we follow this bill passes and we follow it, we will be sued for malpractice. We will need an amendment to protect us from malpractice suits, and we will need an appropriation large enough to cover the related legal costs that will be associated with that.
Thank you. Thank you for your testimony. I will allow for opponents to state a me too, if there's anyone online or in person, but we'll start with online. Mr. Daniels.
Yes, my name's Dylan Daniels. I'm a trans man, South Dakota, and a registered nurse. I would like to just meet you in opposition of House Bill 1080. Thank you.
Thank you. Mr. Torbert.
I'm Dr. Torbert. I'm a board-certified pediatrician and neonatologist in Sioux Falls, and I would like to say I also oppose this bill and will be available for questions regarding erroneous statements citing in the literature for the committee.
Thank you. Do I have anyone else online? I don't see any. Anyone in person? Go ahead.
Morning, Madam Chair, members of the committee. Roger Telling, who's an attorney and registered lobbyist for the Human Rights Campaign. I had a much longer presentation that I wanted to make, but I think I can sum it up with a me too. But I just want to point one thing out, and I think this bill really encapsulates this attitude that if we just leave these kids alone, they'll return to being normal kids again. And I just can't fathom how far from the truth that is and how wrong that is. And we end up denying these marginalized kids the very care and love and treatment that the medical profession clearly demonstrates that they need. And so for those reasons, we would encourage you to vote no on this bill. Thanks.
Thank you. Any further opponents? Welcome.
Madam Chair, Vanita Schmidt, Pure, South Dakota, District 24. I ask that you vote no for this as well.
Thank you. Anyone else as an opponent to HB 1080? Seeing none, we will move on to rebuttal. Welcome back, Representative.
Thank you, Madam Chair. And I really appreciate everyone who's spoken on both sides of the issue. I know there's a lot of passion, and we can see that there are people in our state that care a lot about children. I would just like to address a few of the issues that the opponents have brought up. A lot of this is based on suicide. Does the suicide rate actually go down? Is this the best treatment for suicidality? And I'd just like to point out that the studies that the opponents are using is very short term. I think one of them they said had a 12-month follow-up. And really the only long-term study that exists on suicide rates comes from Sweden. And that shows that yes, in the first couple years after transition, the patient does start to feel better because they got what they wanted, they achieved what they were going after. But the study shows that 5 to 8 years after that transition, the suicide rate is even higher than it was before because they've realized this didn't solve their underlying mental health problems. I'd also like to point out that we are not criminalizing any doctors. We've been very careful in how we crafted this bill, that there is no criminal penalty. So that is just simply not true. It was brought up that doctors need to perform these procedures in order to follow the Hippocratic Oath. But doesn't the Hippocratic Oath also say first do no harm? And we know the studies show that 80 to 90% of children will outgrow gender dysphoria if they're allowed to experience natural puberty. So if your first charge is to do no harm, I think that would land more on our side of the argument. There's been a lot of discussion on, it's stated that you have to go through a lot of counseling and lots of different sessions to even get access to these drugs. And maybe there are some physicians that follow those protocols, and that's great. But the evidence that I've seen happening in our state is contrary to that. I mean, there was a very prominent Dakota News article that stated that an 8-year-old received puberty blockers after only 1 counseling session. So I think there's a disconnect here between what some people are doing and what others are doing. One of our leading hospitals also held a recent gender identity summit, and there a very leading physician recommended, as I stated in my opening statement, the double mastectomies for children under 18. He said it's better to do that in high school than to wait till college. So clearly it is happening here, it's being promoted in our state as well. And I have had parents reach out to me on this issue who have gone through this and are very concerned about their children. they may not wish to testify because they will be targeted if they speak out against this. And as I stated, parents are often not even allowed to access their children's medical records. This is happening in our state. So let's talk about Sweden. Sweden was the premier country that started doing these procedures. In the 1990s, they started working with puberty blockers and cross-sex hormones on minors. So they've had decades of experience. In 2021, they stopped providing these things for all minors, and now it's very limited to small clinical studies because they have seen the damage that occurs. So I think we in South Dakota could look to their decades of experience and learn from that instead of making the same mistakes ourselves. Psychological care and counseling is fully available under this bill. There's nothing that stops that. And it would be great if they would pursue that route. All we're saying is just wait on the medical part of it. The opponents brought up the statute of limitations, and I just wanted to talk a little bit about where that came from, because it might seem a little strange to you. This is based on our current child abuse statutes, so that's why it has an age, and then it says 3 years after discovery, because often when you have trauma as a child, you don't realize it until later on in life. And when it comes to these procedures, you may not know that you've been sterilized until you're actually trying to have a family. So that's why it's so important. I'd also like to point out that we regulate every industry, and physicians are not above the rule of law. And I think it was pointed out in the testimony to the previous bill that physicians can make mistakes. And we have seen in the past that heroin and cocaine were used to be prescribed by doctors. The AMA once ran ads promoting cigarette usage, which is the exact opposite of what they're doing today. And frontal lobotomies were once performed on patients. So mistakes can happen. And doctors are not above the rule of law. On the constitutionality of the bill, our bill applies equally to everyone under 18. We are not singling out anyone based on their gender or sex. And I'd like to point out that the Arkansas case only has a preliminary injunction. It has not been decided that that is unconstitutional. Finally, let's go back to the main point. We all care deeply about children. I think everyone in this room does, and I will not deny that. But we have seen from other countries who have been here and done this, that these procedures are permanent and they are harmful. And we need to protect children and allow them to receive the mental health care that they need before making these permanent life-altering decisions. Thank you.
Thank you. With that, we move to